Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. My name is Sarah Mubaraki. I'm Assistant Professor in Pediatric Dentistry, Riyadh Ilm University. I'm pleased to be the moderator of this evening. I would like to welcome you all on behalf of the Saudi Society of Pediatric Dentistry. As you know, the Saudi Society of Pediatric Dentistry organize a monthly webinar. For today, there is a very exciting plan, including what I know it will be a wonderful lectures, a great speakers talking about important subjects in the field of pediatric dentistry. In our agenda for today, the first presentation will be a new paradigm of the role of pediatric dentist, a guide of occlusion. I would like to welcome our first presenter and our first speaker, Dr. Justin Lee. In 1986, Dr. Justin Lee had his bachelor degree from Seoul National University School of Dentistry, and after that, in 1989, he took his residency in pediatric dentistry. After that, he had his PhD. Currently, he is a visiting faculty and the head of Children's Dental Center, and he's a board member of Pediatric Dentistry Association of Asia. Please welcome with me Dr. Justin Lee.
Thank you very much for your kind introduction, Dr. Sarah, and my long friend, Dr. Mohammad. Okay, I want to start my presentation. I start with my short move that introduces my clinic. Can you hear me? Can you listen? Okay.
Yes, doctor.
Sure. Oops. I opened my practice in 1992. It's now 28 years. And I graduated dental school and I started my career just with pediatric dentistry. So I am now 35 years as a pediatric dentist. Okay, today my topic is reading children's face. I'm living in South Korea. It's Far East. You are in Far West. It's quite long, but we are all Asian people. It's my great honor to participate in this SSPD today. So many dentists just drill and fill the holes without considering the causes of caries. I'm sorry, I want to move. Yeah, okay, that's correct. And so many orthodontists use mechanics just to align teeth without considering the causes of malocclusion. Even when I just taught about orthodontics, even I just taught about caries, I just do the drill and fill the holes, and I'm trying to align the teeth without considering the causes. Many of dentists are doing now like that way. And there's a similar viewpoint Dr. Varela said. It's difficult to avoid the impression that the better the mechanics of the tooth movement have been mastered, the smaller has been the interest in etiological or developmental aspect of the malocclusion. I wanted to ask you, how many children do you meet a day who have a nice occlusion and enough development and primate space? The space in primary dentition must exceed 6 millimeters. Otherwise, there's high possibility of the crowding in permanent dentition. But in fact, we meet so many crowd even in primary dentition now. And sometimes posterior crossbite, and deep bite, anterior crossbite, and open bites. And also, how many your young patient change from ugly duckling state to beautiful swans? the beginning of the above permanent teeth coming, there should be a space between the teeth. It's getting spontaneously closed, like this way. So we can consider about what the causes of malocclusion now. Is it genetic? It came from environmental factors. It came from habit. But now we think about this. First of all, we can consider about genetics. Do you know this family? All of them shows very long face and prognatic mandible. They are Habsburg family. We call it Habsburg jaw. It's an example of the hereditary problem of the jaw growth. And there is some identical twin. They are separated just after 2 years after birth, and they meet again 40 years later. Both of them became a fireman. They have a mustache. They are divorced. They enjoy only the same beer. They grew a dog named same as Mary. It's yeah, very similar one. Even in my practice, I can find a similar identical twin. Both of them have supernumerary tooth just after the left central incisor, behind the central incisor. Even this, even you can see there's some similar pattern of the decay of the primary dentition. It's quite similar. So there's very high rate of the genetic problems, but also we must consider about is the mechanism of the identical twin. I'm sorry, is spoken in Korean. Yeah. The womb is, yeah. The height and their facial form is different. Though they have the same genetic DNA, it's caused by the environmental factor. So we call this epigenetics. So this book was written in 1930, the Western Prize of the dentist in USA. He visited many isolated regions in all of the world, and he found the original tribe did not have any malocclusion, even they do not have any decayed teeth. It's a Korean documentary. They visited Amazon tribe. His mother and daughter, they have very good aligned teeth and good cheeks. And the males of the tribe, they have very rounded face and good looking aligned teeth. But nearby, there are another tribe. They have a culture. They penetrate the low chin with the wood stick. But you can see their face is slightly longer. And most of them have the crooked teeth, like this. It's a prehistoric skull in Smithsonian Museum. You can see that there is no any decayed teeth, and when aligned teeth, even the third molars And the interdistance, or the intermolar distance is quite big. It's around, even exceed 5 centimeters. You can see the posterior nasal hole is wide. It's prehistoric skull. But modern skull shows very narrow, high palate, and narrow posterior airway too. So there is some difference between our ancestors and prehistoric people and the modern people. Though we did not change our DNA, but there should be some other etiologic factors that affect our occlusion. So there is a scholar who studied about this. His name is Robert Corcini. He's an anthropologist. He published this journal and books. And human occlusion has changed dramatically in very recent evolutionary times. And the trend toward narrowing arches in first generation Chinese immigrant to England. And more prevalence of malocclusion in urban children than rural area in India. You can see the change of the grandfather and father and a young son. His chin getting shorter and shorter. Just within 1 or 2 generations, we can see more prevalence of the malocclusion. So this dentist, his name is David Singh, published the epigenetic orthodontics in adults. And Kevin Boyd is a pediatric dentist in USA. He published on DARWINIAN dentistry. So evolutionary, we have some difference between from our ancestors and our modern people. It's caused by the change of our environment. So dramatically increasing incidence of the malocclusion, we must be thinking about the etiological factors. It must come from the environmental factors. First of all, we think about dietary changes and alteration in masticative activity. And second, the increase in allergies and other factors that might obstruct nasopharyngeal airways and interfere with normal breathing. And third, the effect of abnormal sucking habit. Sometimes I add one more factor, that's poor posture caused by watching the mobile phone. Now, so we start to talk about the change of diet. It's a movement of the tongue and jaw of the breastfeeding. During breastfeeding, the breast adapts to the shape of the mouth. The peristaltic motion of the tongue during breastfeeding presses the breast up against the palate. Tongue against the palate, they always press the breast nipple. But abnormal sucking habit usually caused by artificial feeding. The mouth has to adjust any object in the mouth other than the breast. The unnatural forces that can develop can impact the position of the teeth and shape of the palate. Muscle forces always win out of a bone, and so teeth are removed. And buccinate are getting thick. Bottle feeding can separate the epiglottis and soft palate connection, elevate the soft palate, drive the tongue back, and alter the action of the tongue. So you must encourage breastfeeding. In such an artificial feeding patterns, if it prolonged bottle use and using the pacifier, sippy cups, and keeping food in the mouth too long, or digital thumb sucking or blanket sucking, that all of them cause negative pressure in oral cavity. The negative pressure in oral cavity causes collapsed arch, high vault of palate, nasal constriction. It causes frequent otitis media, the middle ear problems. So upward force on palate and vacuum can alter oral development, even the palate getting high palate, even sometimes alter the nasal septum. And prolonged sucking habit usually retain the infantile swallowing pattern.
Inward and backward muscular forces. This drives the development in the opposite direction to natural growth. There are many variations of this, while the elements of the cycle remain replayed. The backward movement of the mandible is slower versus the teeth to improve the development.
We call it reverse swallowing or retained infantile swallowing pattern that always causes some constriction of the lower arch and upper arch too. It sometimes make a crowding or periodontal problems or TM joint problems too. We can also see the changing of the musculature. If the hyoid bone is pulled down, like such an prolonged sucking habit, it causes the infantile swallowing pattern. The symphysis is getting longer, tongue drop down, and condyle getting narrower, and molar is inclined inside. It also causes the narrowing the airway. So we cannot tell the hen and eggs, the swallowing pattern, or I'll tell you later about the mouth opening. What is the real reason of the problem? But the retained infantile swallowing pattern causes such big problems. Even the level of activity of masticatory muscle does regulate the development of the cranial and facial skeleton. The increase in function of the masticated muscle is associated with anterior growth rotation pattern of the mandible and with well-developed angular, conoid, and condylar processes. So that means young children must chew enough. But modern food is too soft. They seldom chew, they just eat some like soup-like one and non-chewable food they are eating now. It's a big problem. Now another topic is about breathing. This experiment was done in the late 1970s. Dr. Harvard blocked the young monkey with a silicone, and the monkey let the monkey breathe through their mouth, not nose. And 1 year later, he examined again. All of the monkeys developed the malocclusion, and the tongue acquired a new shape in all experimental animals, but particular shapes varied by each family. In general, it became more narrow and more pointed. Most animals developed a groove along the midline of the tongue, with the palatal vault from the tube for airflow. After 1 year later, he removed the silicone blocks from the noses. Now the monkey started to breathe the nose again, but still the malocclusion remained. So have you ever seen any malocclusion in mammals except human and sometimes bulldogs? All mammals breathe through the nose, not mouth. Until 4 to 6 months after birth, babies breathe and swallow at the same time, but after dance of the palate and epiglottis is separated, tongue became the part of the airway. It makes it possible to speak, but there's a big room the pharyngeal room, pharyngeal space makers can speak, but it also makes us breathe through our mouth, exhale and inhale too. This uniqueness of human airway cause not only the malocclusion, but it also caused obstructive sleep apnea. So speech is uniqueness in human race, but it's also the Achilles heel of the human race too. It causes more prone to choking and dying. This handsome boy, but at his 14th birthday, somebody gave him a jawbell as a present. After then, his nose began to block because of the allergic rhinitis, causing him to breathe through his mouth. His face changed like this way. Similar case I have my patient. This good-looking boy changed his face getting longer, and his head getting more forward posture than before. Because he has chronic rhinitis, he always open mouth posture. We think our suture is very tight, but you can see.
I take the maxilla between my thumb and forefinger and to move it in relation to the other bones.
Yeah, our joint is quite loose. So if we open our mouth, our face must grow like this way. But if we open our mouth, if the lower jaw do not support the upper jaw, the maxilla drop down. And the lower jaw, there's no way to drop down too. And it obstructs the airway, so it's getting remodeled like this way. So you can see the difference of the face. I call this yield to gravity, because this suture line is very weak joint. And another explanation came from the Herman Ramirez. Is my old friend. He's now in Canada.
The normal or physiological way of breathing is through your nose. Breathing through the nose permits to purify and irrigate the structure inside. In that way, the air entering into your nasal and oral pharynx, your throat, is not going to heavily affect tissue in the adenoids and tonsils, which is the last barrier to catch harmful particles in the air before it reaches your lungs. Besides carrying the air, also bringing stimulants that prevent that way allows the air to pass directly into your throat, where the adenoids and tonsils are located. It's more difficult for the nasal breathing than you would get. Your lower jaw has to come down as well as your tongue has to rest on the floor of your mouth. Breathing through the nose is the correct way. Your upper jaw is negatively affected, resulting in an error. The upper Open bite, as your upper and lower front teeth do not touch when you close it.
So I want to understand the really repeat problem can be caused by open mouth posture and breathing through mouth. And next topic is about sleep. His name is Christian Girimino. He passed away last year. He's very famous, the sleep study. He worked in Stanford University in USA. In fact, he had been a French people and moved to USA in 1970s. He founded all the sleep research and studies. But we must know many children suffer obstructive sleep apnea. So we must know about the symptom. If the children snore, it's not so heavily as adults, but they can snore, and they show hyperactivity. They show developmental delay and poor concentration, and bedwetting, and nightmares, night terrors, headache at the morning, restless sleeps. They turn around all night, and even they eat some food before sleeping. And large tonsils, noisy breathing, and chronic running noses, frequent upper airway infections. If you find any children who have at least 3 or more signs of these symptoms, they need a sleep study. Because obstructive sleep apnea is caused by not only tonsil and adenoid. The investigation demonstrated the adenotonsillectomy in non-obese children does not cure obstructive sleep apnea in many prepubertal children. And the oral-facial anatomical problem plays a pivotal role in the development of obstructive sleep apnea in children. Moreover, some subjects to these anatomical problems may be amenable to orthodontic treatment. So, pediatric obstructive sleep apnea in non-obese children is a disorder of oral facial growth. If the poor growth of oral facial growth cause obstructive sleep apnea. And we also must consider about tonsil. When we can see the kissing tonsils, big tonsil, they obstruct airway. And adenoid can be examined by the cephalometrics. You can see the adenoid here, here, here. This airway should be at least 11 millimeters. But compare this is if you have the water bottle, you can see the top of the bottle, cap size, and the base of the bottle. This big change of the airflow. It causes the adenoid phase. This boy, a very big adenoid, there is a pulling underneath the eye, and nasolabial angle is getting bigger, and this has chin, allergic shiner. We can see flat cheek, and this narrow airway. The biosleep study is apnea score is more than 38. That means it's awake 38 times on hour. So after tonsillectomy and adenoidectomy, you can see the difference. Even the big tonsils sometimes cause open bite by tongue thrusting. So after tonsillectomy, open bite spontaneously corrected. These were studied by Linda Aronson in Sweden. Now we start reading the faces and many portraits and figures. First, you can see the tilt back or forward head posture. If anyone who tilt back their forehead means poor growth of the low face. By this blue line is the Bolton norm compared to the forehead. His face must grow like this line, but it's poor growth. And anyone, if they open their mouth, open mouth posture, cause melting maxilla, maxilla getting flat. Although in another way, if anyone have good cheek line, always they looks good. Cheek must parallel with nose. The face more looks dynamic and more fancy, more attractive. So the cheek must be parallel to the nose. It's ideal. But if the cheek line 30 degrees to bridge of the nose will be hooked. So you can see this actress and her. So the cheek is parallel to the nose. The right face, the cheek is just dropped down, a very flat cheek. So we call this horizontal growth is vertical growth. And another characteristic is the drop down of the maxilla means gummy smile. Any kids, they show the gummy smile means their upper jaw dropped. And another sign is sclera under the iris. You can see the sclera on the iris. That means the upper maxilla is dropped. And long face syndrome also show the dropping the maxilla and then open mouth posture cause this long face and open mouth, open bite. So now you can see the difference. Well developed jaw, large eyes, straight nose, wider face, compared to poor definition of a cheekbone, crooked teeth, narrow face, small airway, forward head posture, tired eyes. So every face is linked together, not only the malocclusion. So you can see the difference of the airway size. Can you see the difference of the faces? This boy also show the clockwise growth pattern, narrow airway. This red line means his face diagram. You can see inside of the mouth, there's a wrinkle in palate, a high palate, then crowding and lingering inclined molars and folded tongue. So sometimes you can imagine the inside the mouth just by looking at the face. So malocclusion is a sign of craniofacial discrepancy. We must always remember this. Sometimes we can see some local factors such as missing or spondylometaphysis can cause some malocclusion, or early loss of the primary dentition can cause a crowding like that way. But we must know most of the big problem of malocclusion is a sign of a craniofacial discrepancy. So my hypothesis is around 6 to 9 months after birth, subpalate and epiglottis are separated. After then, the baby started to speak. And some conditions such as common cold make baby breathe through their mouth. It can make a habit that cause sinus congestion, resulting in poor maxillary growth. It causes downward growth of maxilla, like water-filled balloon in sinus. Because in sinus, there's a secretion of the water more around 1 liter a day, we must breathe through our nose that make vaporize the water. So our inhaled air should be humidized by such water. But if we breathe through our mouth, there is no way to vaporize such water, so it congested. And it worsens further due to low tongue posture, and because of soft diet, the jaw getting weak, and sucking habit that leads to collapsed arch and jaws, it getting worse. So first of all, we must watch the children if they open the lips or mouth. After then we can watch their muscle tone and other habits too. So to have good occlusion, the lips must together, breathe out through the nose, and tongue pressed on the spot, and sound. And swallow with masticatory muscle, not with orbicular oris muscle. That means if we use the orbicular oris muscle, means the infantile swallowing pattern still retained. And there should be no parafunction, such as thumb sucking or pacifier sucking like that. So, what can be a choice? As a pediatric dentist, we must find the causes of open mouth posture first, and let them breathe through their nose. So you can find some more information about Buteyko method. You can find the YouTube or Google, and Buteyko is the Russian physician. I'll tell you some more later. And muscle functional training should be started just after birth. That means there's some more programmed weaning. Weaning food must be tough and hard. And we can do some muscle training with some appliances such as trainer system or DF line or pre-ortho, and many ready-made tools we have. And I also introduced to you the orthotropics. The concept of orthotropics is the correct the growth. And I wanted to introduce rampa. Rampa means the right-angled maxillary protection appliance. Yeah. So I want to show you this movie first, baby weaning. And 4.5 months after, if the baby can start sit up, it can start the weaning food. Most important thing is never use a spoon. Let the baby hold the food with their hands, and hands also can taste the food, hot or cold, or hard or soft. And they can eat everything if they sit up. And if you find the crossbite at early stage of their life, it usually 1.5 year. If you find such a crossbite, let the mother use the finger to press the incisive foramen, premaxillary suture area. If they stimulate and push up, the crossbite can be corrected by the mother's finger. I have many cases of this. Before 2.5 years, it can be corrected by mother's finger. And if you find any kids, if they start to thumb sucking, it's the time to stop. Some textbook tests we can wait until 4 or 5 years. It's not good. If you find any kids any baby, if they start to thumb sucking, it's the time to stop. Find a way how to stop it. The counseling is always best. If they stop the thumb sucking, you can see the change of the dentition like this. And Buteyko method is always emphasize lip sealing. You can get some more information through the Google. And in my clinic, we surprise this muscle functional therapy, tongue exercise, and lip sealing, like that way. So sometimes I'm using the trainer system too. This baby referred from the sleep center because of the poor sleep. The bite was like this. I use a trainer for kids for 1 year and 4 months. You can see the changes of the face. The fourth adipose is corrected, and dentition is the more deep bite was corrected. You can see the change of the airway from this to this. And I wanted to introduce Biobloc Orthotropics. His name is John Mew. Is there anybody who knows about him? He's now 92 years old and he's in his house. He developed the concept like this because he insists every malocclusion caused by drop of the maxilla to down. So inversely, if we correct that, it is correction of the malocclusion. So you can see this movie. If we move up the maxilla up and forward, and then if our lower jaw keep the correct posture, our mandible will be changed like this way. I think all of you want to do this, watch again. Can you see the cheek line too? If we know about the problem of malocclusion, we can find a way how can we invert it. So after learning from him, I tried to apply in my practice. So I show you some cases. This boy, you can see the class 2, but never push in the upper teeth to back, never retract. So I tried to change his face like this way. You can see the change. You can see the change of the airway too. You can see that his retro profile. And another boy, he shows deep bite. I expand this arch and move his front teeth to upward and forward. After then, I use this, let him keep the correct posture at least 22 hours a day. You can see the changes in his face. Another boy, his face is going back, is showing the clockwise growth pattern, but there is no any crowding or any malocclusion. But I can say his face is getting worse. So I expand this upper arch and move up his front teeth to upward. I make an open bite intentionally. After that, I pull out the primary teeth molars and keep the correct posture against the change of his face. I open the airway too. This another boy. We can misdiagnosis is upper teeth too far front, but never. I make it more front move forward and expand and try to lower jaw at the correct posture against the changes, change the faces. This goal 2, script and looks class 2. I expand and move her upper teeth forward. And using this device, it never retract the upper jaw, and then patient must do correct posture, otherwise these legs hurt their gums. It make the lower jaw close this way. You can see the difference. This boy shows crowding. If we just do weight, and he will someday need the 4 premolars extraction. But when we start somewhat earlier, never do serial extraction, try to expand like this way. Temporarily we can make the open bite, but if we make a correct posture with this appliance, the open bite corrected and face getting better. So it's a first upper, front, bottom, lateral, make a intentional open bite and expansion, and using we call the Biobloc stage 3 appliance that make the correct posture of the lower jaw. It close the open bite with rotation of the lower jaw counterclock pattern. So you can see the change of the face is like this way. This goes to, you can see the change of dentition and face. And even open bite, never use the tongue break, because we must think the arch is a cage and tongue is a tiger. The open bite means the cage is too narrow, too small to keep the tongue inside. If the real open bite, if you find, the teeth will be separated and there should be enough space. But you can see there is no any space between the lower teeth. Even the upper teeth, there is not enough space. That means arch is too narrow. So I try to expand. I make more big open bite to make more room for tongue. After then, I'm using the early extraction of the primary teeth and using the positional appliance. I change like this way. So you can see the change of his face like this. This movie is made by the William Hang. You can visit his website. If we do extraction and retraction, as time goes by, the face getting worse. Contrary, if we move the upper jaw forward and then lower jaw forward using the positional appliance, the face getting more attractive. It's a case of extraction and retraction when the finishing the orthodontic treatment, but as the times goes by, the face getting worse. Contrary, if we make it forward growth like this way, the face getting more attractive. So when you meet young patient during the primary dentition and early mixed dentition, there is no chance to extract premolars if we're using this Biobloc Orthotropic concepts. But still, there's some problem if we find such a tissue in face. Until now, we using this reverse pore headgear, sometimes called this D-layer mask. Dr. D-layer now is 95 years old. But this make our lower jaw move back and face getting longer. Isn't this a disadvantage? Even sometimes it relapsed. So many dentists worry about this. They try to move upper jaw forward without moving back the lower jaw. So this some semi distraction osteogenesis. And one father dentist using this helmet to his daughter to protect upper jaw. And this crane appliance using neck brace and then hold the elastic to this. But this rampa is developed by Dr. Mitani in Japan. He never used the lower chin and forehead, and he got some retention from the back of the head using this. So you can see the change of his face like this. And this face is class 3. Using his appliance, I correct his face like this way. You can see the difference by X-rays. Dentition change like this. And this midfacial this deficiency corrected by Rampa like this way. It takes around 1.5 years. And this boy also corrected like this using Rampa. Even this narrow face and too narrow and crowded face, even the canine proclined almost horizontally, using the rampa like this way, and his face change like this way. So I let you know about some method about breathing exercise and muscle functional therapy and Biobloc Orthotropics and rampa therapy. But still, I cannot tell you the future. This girl is 17 years old, and 1 and 7 months later, and 18, he visited my office again. His face changed like this way. During this period is our Korean, the high school last years. They must prepare the entrance examination of the university. It's very, very hard time for them. I think she developed a clenching that causes such a big difference of the face. And this boy, I tried to change, I tried to using the trainer system, but after 4 years later, his face changed like this way. Still, I do not know the reason. But the mother told me he has some nose broken problem. But his face changed like this way. So I think there is some treachery of God. Yeah. We should be humble. So I try to summarize my today. We think about the causes of malocclusion. Otherwise, we just do a symptomatic treatment. And malocclusion is highly related with facial development and sleep and respiration and the swallowing patterns. And we must catch as early as possible the sign of a malocclusion, and we can start early intervention. And there can be some alternative treatment, not only the conventional orthodontic treatment. We can use the functional appliance, not just a functional appliance. We can use some muscle functional appliance and Biobloc Orthotropics, and we can use rampa. So to close unfitting door, we should look at the frame first before shaving the door. So if we find malocclusion, we try to find the try to find the real reason. So always watch the children's face and posture first before examining their teeth. Postural changes, reduced muscle function, cause lengthening of the face, airway can be compromised, that cause the change of the tongue, function and posture. It causes reduced tongue space, narrow short arches, maxilla setback and down. It causes malocclusion and associate many musculoskeletal problems. So we care children. We should take care of their growth and development. We must try to develop their oral function and form because we are pediatric dentists. Thank you for attention and forgive my poor English.
Thank you, Dr. Justin, for really an important topic and well presented. Really, it's a very important topic, and those cases we face it every day in our practice. And sometimes we don't know really from where to start. Thank you for wrapping up all this information in this few minutes that really was condensed and well presented. I really want to take the chance to thank Dr. Aziz Al-Johar and her team and the society to invite you. Really a distinguished speaker. I enjoyed personally, and I'm sure all our audience are enjoying it to the maximum. I'm 100% sure about that. Thank you, Doctor, again for your presentation. And let's start. And thank you. Let's open the time for questions, or if you have any doubts regarding the topic, please don't hesitate to write in the chat or send us your question. And waiting for their questions, I want to ask you, Doctor, as a pediatric dentist, and those cases are really comprehensive, and they need a and they have a multifactorial in those cases, and really we need to work as a team. From where we can start? Should we start parallel with orthodontist, or it's our role here in those cases to start and to do a planning? If you can, please let me know.
Yeah, the timing is very important, but I always compare with the curious management. If you find a white spot in the front teeth, what do you do? Will you just wait until that make a cavity and even wait until some symptom of the pulp? Never. We must do early intervention, such as the fluoride application and toothbrushing instruction and diet controls. So if we find any sign of the malocclusion, it's the time of the start. Never wait. If you find any causes of malocclusion, it's the time to start intervention. But sometimes it just needs some instructions, such as breathe through the nose and keep good posture. But sometimes we must use some kind of mechanics. But if we just delay until the full change of the primary dentition to the permanent, it's very, very late. After then, we just can do symptomatic treatment. Just align teeth, we must retain for whole their life. Otherwise, it will be relapsed. It always documented well by the Dr. Richo in Washington University. So most of the just conventional orthodontic treatment using the braces and wires, it relapses more than 90%. So we try to find the etiological factors first and try to find the solution. It can be very simple one, it can be very complex one. But it's time to start. It must be started with our research, otherwise we must make a consultation with some more expert about this. Never delay. if you find a white spot, it's time to start. Change their lifestyle, start the fluoride. Like the same way, it's time to start correct their habit, their posture, and train something. We can use some appliances.
That's clear, doctor. Thank you. Just to make our presentations a little bit funny, I just want to share something. Malocclusion is very common. I have one cat at home, and he exfoliated his primary teeth, and the permanent teeth of my cat came procline, which he cannot close his mouth, and he ended up by extracting two canines, and that's so funny that even in animals face also malocclusion. So let us check if there is more questions. Most of the people, they are really thanking you, doctor, for your presentation. And just one more question. If I want to have a book as a reference, which do you recommend as a book to be in my library? And most of the pediatric dentists, they are always concerning about this. What do you suggest for us to have?
Yeah. I prepared something. Can you let me open my presentation? Okay. I wanted to introduce the causes and cure of malocclusion, written by John Mu, but it can be bought. It can be bought only from his website. So the website address is orthotropics.com. Orthotropics.com. And another book is Joe's. So written by Sandra Khan and Paul Elhi. Is very easy book to understand our changes of our evolution and epidemiological problems. It's very easy book to read. And recently, there's another book was written by James Nestor. The book name is Breath, the breathing, breath. And the last one is the Sleep Interrupted. It's written by Stephen Park in US. He studies about the sleeping. So you can get some more information and some insight about it. All problems is connected together. Breathing, sleeping, and chewing and eating, it connected with malocclusion. So if we solve our malocclusion, it can cure the sleeping problems or breathing problems together. So we can do more holistic approach to our growing generations.
Thank you, Dr. Justin, again for your time and for your cooperation and for your answers. Let's go for the second presentation for today. This topic is very important and interesting, especially for the fresh and new graduates. Nowadays, they are seeking for programs over all the world, and it's not easy to have acceptance in a professional and good program. Nowadays, especially in pediatric dentistry, it's one of the hardest programs to have accepted in. So we are lucky to have the second presentation with Dr. Mohammad. Dr. Mohammad Keshan, he graduated from Jordan University, Science and Technology. After that, he traveled all the way to Korea, so he got the Korean board and Ministry of Health, King Faisal Hospital. They are really lucky to have Dr. Mohammad in their team as a senior registrar. Please, Dr. Mohammad, can you open your microphone and share your screen? Thank you.
Thank you, Dr. Sarah, for having me today. I am very glad to join you. شكرا على إتاحة الفرصة للتحدث عن my experience in Korea. I will talk today about the pediatric dentistry postgraduate program in South Korea. My lecture will talk about KD, about Korean medical training program for Saudi dentists, and about Korean University and Training Center and life in Korea بشكل عام. KD هي اختصار لكوريا Health Industry Development Institute. Its service to enhance health technology and research development planning capability and to promote health technology utilization and establish the foundation for growth. Globalization, it increased the global market access and lead policy planning in the health industry. KD supporting hospital overseas expansion, support overseas marketing and export in healthcare industry, and support the business to attract foreign patients to Korea. بالمناسبة دولة الإمارات العربية المتحدة عملت مستشفى مصغر لسول ناشونال يونيفرسيتي هوسبيتال في لدولة الإمارات، واعتبرت دولة كوريا الوجهة الأولى الأساسية لعلاج المرضى الغير قادرين على العلاج أو لا يوجد إمكانية لعلاجهم داخل دولة الإمارات العربية المتحدة. Its vision, they want Korea to become a leading nation in the global healthcare industry and to build policy supporting system for sustainable development. It's a strategy to enhancing awareness of Korean healthcare and expanding overseas network, leading healthcare industry by cooperation with other industry in the Middle East or around the world. About now I will talk about Korean medical training program for Saudi dentists. The goal of Korean medical training program is to provide the experience and the skills of Korean medical and opportunity to learn advanced technology and treatment system in Korea. The history of this program and agreement, this agreement done by KD and the Middle East government and Korean Minister of Health and Welfare. Saudi Arabia was the first country to make this agreement, then Kuwait, بعدها البحرين, and last country was Oman. Current status, around 17 completed the program and they are now in Saudi Arabia. أكملوا تصنيفهم as a senior register بعد إنهاء امتحان الهيئة الخاص بالتخصص, and 28 participating still in Korea completing their study. Training Institute في كوريا هي عبارة عن 4 مستشفيات، هي من أكبر مستشفيات في كوريا جميعها في العاصمة سيول. First Institute is Seoul National University Dental Hospital وهي أقدم جامعة في كوريا. تليها كيونغهي University Dental Hospital and Seoul St. Mary Hospital Catholic University of Korea, and last one Yonsei University Dental Hospital. كل جامعة تقريبا تتوفر فيها جميع التخصصات، ولكن ليست كل الجامعات تقبل في جميع التخصصات. على سبيل المثال Seoul National University can accept in pediatric dentistry, orthodontics, and maxillofacial. Kyunghee in orthodontic, Seoul St. Mary in orthodontics and in maxillofacial. Yonsei in prosto and maxillofacial. Recently they start to accept pediatric dentists and orthodontists. Training department in every hospital in Korea include conservative dentistry, oral and maxillofacial surgery, orthodontic, pediatric, periodontic and prosthodontic. للمعلومية الاندودونتيك مشمولة مع الكونزرفاتيف دنتستري في كوريا، لا يوجد تخصص أو بورد للاندودونتكس في كوريا. duration of the program مدة البرنامج تقريبا 4 years مقسمة إلى 3 أقسام. القسم الأول Korean language program for 12 months. Then there are 3 months as pre-training. Then the clinical training for 3 years. المرحلة الانتقالية ما بين سنة اللغة والكلينيكال تريننج أو ما يسمى بالبري تريننج أيضا مقسمة إلى قسمين زي ما هو واضح معنا في السلايد. البري تريننج باي كيدي اللي هي Korean Health Industry Development Institute حيكون المبتعث أو المتقدم بالتخصص يحضر محاضرات عن الكوريان culture and Korean medical law, medical terminology in Korean. بعدها حيكون في عنده امتحان. بعدها سيكون في عنده training pre-training by training institute. حيتوجه المتقدم والمبتعث إلى المستشفى لحضور أو لتطبيق اللغة أو إلى تطبيق ممارسة أكثر للغة في المستشفى لمدة 2 شهر قبل ما يبدأ البرنامج بشكل فعلي. بعدها في بداية مارش من كل سنة هي بداية السنة الأكاديمية في كوريا. Scope of the programs: Korean language program, a year-long program to learn advanced Korean for upcoming clinical residency program for dental resident. Pre-training program, 3 months, as we said, mandatory program in order to apply for the hands-on practice permission on the medical service and law in Korea. Clinical training program, undergo clinical training by department including hands-on medical practice. Korean language program وهي السنة الأولى من بداية وصول المبتعث في ديسمبر من كل عام. Mandatory to fulfill a requirement in order to participate in the clinical training program based on partnership between Korea and Saudi Arabia. لن يسمح لأي متقدم بالدخول إلى الانستيتيوت أو إلى البرنامج الهوسبيتال يونيفرسيتي إذا لم يجتاز اختبار اللغة الكورية. اختبار اللغة الكورية يطلق عليه TOEIC وهو Test of Proficiency in Korean وهو أعلى امتحان لغة في كوريا. امتحان ليس سهل، امتحان يتطلب مجهود كبير ومجهود مضاعف لكي يتم تجاوزه. بالإضافة الريكويرمنت الثاني في سنة اللغة اللي هو جريد 3 في Language Institute. ما يعيبها امتحان التوبيك واللي حاولنا مع الملحقية السعودية كثير انه يغيرون في الاتفاقية لامتحان التوبيك. هناك امتحانات ثانية للغة ولكن أصروا على هذا الامتحان الملحقية الثقافية السعودية لعدة أسباب. الامتحان هنا يوجد للامتحان 5 تواريخ ثابتة سنويا. بالتالي قد يبدأ المبتعث في ديسمبر ولكن يفاجأ أنه مثلا بعد 2 شهر بداية أول فرصة للامتحان أو بعد 2 شهر برضو في امتحان ثاني. لكن هو فعليا لا يمكن أن يكون المتدرب أو الطبيب قادر على اجتياز هذا الامتحان قبل 6 أشهر من الدخول في بداية اللغة الكورية. أيضا هناك جريد 3 اللي هو داخل الانستيتيوت before participating pre-training يتطلب الحضور 90% of attendance و passing every quiz and exam. فبعض الطلاب مغلب المتقدمين أو الدكاترة اللي هناك في كوريا تقريبا بنسبة 99% they pass the TOEIC exam. Some of them from the second or third chance. I passed the exam last chance. Mandatory program, pre-training program, mandatory program in order to apply for the hands-on practice permission based on the medical service law in Korea. Pre-training تنظمها أول شهر تنظمها هي المنظمة نفسها كيدي، مدتها شهر واحد to learn Korean culture and strengthen the basic on medical of Korea. To learn medical Korean terms تعقد في ديسمبر، والإيفالويشن يكون exam 70% and participation 30%. Pre-training by training institute مدتها 2 months and to be familiar with the hospital environment and make a training plan with a supervising professor. تعقد أيضا في جانوري وفبراير لكي يتم بداية السنة الأكاديمية مثل ما ذكرنا في مارس. مكانها التريننج هوسبيتال، والمطلوب من المتقدم أو المبتعث to be observer only during this 2 months. الإيفالويشن خلال المسيرة في كوريا حيكون عبارة عن 4 exam. First exam اللي هو Korean language exam topics. Then they have a first month pre-training exam for the, as we say, the Korean culture and medical terminology. Then yearly clinical exam and competition exam. The evaluation, pre-training assessment by KIDI and pre-training assessment by hospital, quarterly assessment. This quarterly assessment will start when the dentists start in the hospital institute. Every 4 months, every hospital will send a report to the Saudi Culture Mission and لكي يعني يتم تقديم تقرير كامل عن مدى تطور الطبيب في التخصص، علاقته مع زملائه، الاتيتيود، الاتندنس and yearly assessment. A pre-training assessment by KIDI and pre-training assessment by hospital is required for hands-on practice application. نيجي للخطوة المهمة هنا how to apply. التقديم على البرنامج الكوري يتم عن طريق الويب سايت. إذا أحد يحب يصور الشاشة، هذا هو الموقع الرسمي للتقديم. عند فتح الرابط سيكون في خيارين على الميديكال بروجرام والدنتست بروجرام. Every November to December مدة التسجيل تستمر إلى مدة 2 شهر. بعدها إلى مدة 1 شهر إلى 1.5 شهر يتم المفاضلة بين المتقدمين ثم الإعلان عن النتائج. The approval procedure is as follow. Approval by Training Institute بعد أن يتم إرسالها عن طريق الويب سايت. بعدها سيتم الموافقة من قبل Ministry of Health in Korea، وهي عادة إجراءات روتينية. بعد المستشفى جميعها تكون إجراءات روتينية. في حال أنه المتقدم حصل على القبول من المستشفى، فالأشياء الباقية حتكون أو الاستبات الباقية حتكون كلها روتينية فقط. Then حيرسلوا الابروفال إلى المتقدم في السعودية لكي يبدأ في التقديم على الابتعاث والحصول على السبونسر. بعدها في ديسمبر يجب أن يتقدم بطلب الحصول على الفيزا من السفارة الكورية أو القنصلية الكورية. بعدها لازم يكون في كوريا في نوفمبر. على سبيل المثال المقبولين العام الماضي يجب أن يكونوا الآن حاليا في كوريا. الدوكيومنتس المطلوبة للاختبار للقبول في كوريا: ميديكال بورد لايسنس اللي هي التصنيف من الهيئة السعودية للتخصصات، الأوفيشال ترانسكريبت، السي في. يفضل أن يكون السي في يحتوي على مدى انخراطك في التخصص، الورك شوبس اللي حضرتها، الكونفرنس، إذا عندك أي اتاشمنت في الكورس. حاليا طلبوا أيضا الكيسز اللي أنت عملتها. الكوريين يدققوا في السي في بشكل واضح وقوي، يعني كل كلمة حتكتبها في السي في حيكون محط اهتمامهم وحيطالبوك فيها. فيعني يجب أن يكون السي في يعني يحتوي على مصداقية عالية حتى ما يبنوا عليه أشياء ما تقدر أنت تحققها لما تروح لهناك. Verification of employment سواء كانت في قطاع عام أو قطاع خاص، يجب أن تكون 3 سنوات وأكثر. new recommendation letter, certificate of immunization، وهذه دائما تجينا أسئلة كثيرة عليها إيش المقصود فيها. في كوريا هي موجودة لكل الأعمار تقريبا وليست محصورة في الأطفال. بإمكان المتقدم أنه يأخذ أسماء الفاكسينز اللي حصل عليهم أثناء فترة الطفولة ويحطهم في أي فورم ويختمهم من مستشفى أو مركز صحي، فحتكون كافية. verification of internship، passport. الطلبات الجديدة الآن اللي هي الكيس ليست والبورتفوليو، وهي عبارة عن should include 10 cases, scaling and root planning 2 cases, root canal treatment 2 cases, single crown and posterior 1 case for each, comprehensive case to 2, and every cases should have photograph and X-ray for all cases, follow up at least for 3 months. المقصود ب state of result of Saudi dental licensing exam اللي هو اختبار الهيئة اللي بعد فترة internship، أو إذا كان اليرلي اللي يتقدمون لأي امتحان، خاصة امتحان البورد السعودي. المطلوب أيضا ليس فقط ورقة الامتحان أو الاجتياز امتحان، المطلوب أيضا أن يكون مختوم ومصدق من الهيئة السعودية للتخصصات الصحية. بالنسبة للتوفل أو الآيلتس it's optional not mandatory، ولكن ممكن تعطيك يعني تعطيك أولوية عن المتقدمين الآخرين. بالنسبة للvacation during the programs in Korea same as Korean resident during clinical program، وهذا يعني أنها 10 أيام عمل. غالبا الريزيدنت الكوري ما يأخذ إجازة إذا كان السوبرفايزر في العمل، ولكن مراعاة للمسافات وأوضاع المبتعثين يسمح للمبتعث السعودي بأخذ إجازة كاملة لمدة 10 أيام ماكسيموم 15 يوم عمل سنويا لزيارة البلاد. No special vacation during pre-training program لأنه برنامج يعني intensive course during 3 months so no special vacation during this period. Short semester break during Korean language program for 1 to 2 weeks. As we said, there is 3 grades in Korean language, so there is 1 week or maximum to 2 weeks as a vacation between each grade. In the case of leaving Korea for any reason, training should inform Korean Health Industry Development Institute. As we said about the new regulation and policies, case list and portfolio, any format, set of result of Saudi dental license examination, certificate of English proficiency, regulation and policies, annual exam. Trainee must take and complete annual exam on every January in order to promote 2nd and 3rd years. Completion exam, a trainee must take and pass completion exam 2 months before and end of training. If a trainee doesn't pass the completion exam, no certificate will be issued. References for Korean language. بالإضافة للكتب التي يتم اعتمادها من قبل الانستيتيوت، هناك كتب يعني أكثر أنا بالنسبة لي وجدتها مفيدة، هي سلسلة كتب تسمى Talk to me in Korean، هي English Korean. أيضا بعض المواقع على وسائل التواصل الاجتماعي مثل تويتر أو الفيسبوك ممكن أنها تكون مهمة ومفيدة في تعلم اللغة واجتياز اللغة خلال هذه السنة. للانخراط أكثر في المستشفى، اللغة مهمة بشكل كبير جدا داخل المستشفى، خصوصا في التخصصات اللي تتطلب أو جميع التخصصات تتطلب يعني أخذ medical history, dental history from the patient. نحن كنا نواجه مشكلة مع خلال السنة الأولى مع البيدياتريك patients بحكم الشكل، بحكم الأكسنت. أنت ما حيمديك أو يعني هي فروقات فردية، ولكن ما حيمديك تجيب الأكسنت الكوري مضبوط في البداية، فممكن يكون الطفل خايف منك، ممكن يكون رجال كبير في العمر ما قاعد يفهم على الأكسنت حقك بشكل واضح. طلاب أطباء البروستو كانوا يعانوا صراحة بشكل كبير، فمطلوب صراحة أنه يكون خلال السنة هذه يكون في جهد مضاعف لكي تستطيع أنك تحصل على أكبر قدر ممكن من إتقانك للغة الكورية حتى ما تواجه أي مشاكل في الميديكال بروجرام. About Korean University ranking. Overall ranking of Korean University nationally, Seoul National University تحتل المرتبة الأولى في الجامعات الكورية، تليها يونسي، تليها كيونغ هي University and Korean University. About Seoul National University globally خلال آخر 10 سنوات يعني تقدمت حتى كانت في المرتبة 60 ولكن تراجعت إلى حتى المركز 85. أيضا الريسيرش رانك هي في المرتبة 60 حسب آخر إحصائية أو حسب آخر ريبورت صادر في عام 2021. Clinical training curriculum during 3 years of a program. The trainee will be familiar with developmental anomalies and oral disease, restorative treatment in children and adolescents, bulb treatment of primary and permanent teeth, tooth extraction in children, management of orthodontic problem, dental caries and prevention in children and adolescents, prosthodontic restoration in children. Trainee must present case reports or publishing at least 2 research papers during 3 years. هناك مؤتمرين يعقد بشكل سنوي في كوريا، هو مؤتمر الجمعية الكورية لطب أسنان الأطفال، ومؤتمر آخر أيضا المشاركة فيها يعني mandatory. يجب أن تقدم كيس ريبورت، يجب أن تقدم محاضرة خلال كل سنة. They should fulfill the academic requirement to pass each year. استكمالا للtraining curriculum, minor oral surgery like odontomes, like supernumerary teeth, ranula, macules. It's very common to see it every day or every week. Treatment of traumatic injuries and important thing, fabrication of space maintainers. خلال السنة الأولى لا يسمح للتريني بإرسال أي space maintainers أو prosthetic removable أو functional appliance للمعامل. يجب أن تتم عن طريق الطبيب نفسه. فأنصح أي شخص يعني يحصل على قبول في البيدياتريك دنتستري أو الأورثودونتيك ديبارتمنت إن يرجع يراجع الواير بندنج، يحاول إنه يمارس أكثر، لأنه يعني كنا بعض الأحيان خلال الجنرال أنستيزيا إذا تغيرت مثلا خطة الطبيب من بلبكتومي إلى إكستراكشن أو whatever the cause، ممكن إنه يعمل الامبريشن ويقول لك خلال نص ساعة تخلص لي الباندان لوب. فلازم إنه يكون كل شخص يعني well trained in space maintainer or in bandana loop or sorry in wire bending. Orthodontic treatment with fixed appliance, dental treatment under nitrous oxide, oral sedation, IV and general anesthesia. سول ناشونال يونيفرسيتي and جونسي يونيفرسيتي توفر فيها هذه السيرفيس بشكل كامل. باقي الجامعات لا تتوفر إلا الجنرال أنستيزيا. فأنا أفضل صراحة أن يكون للمتقدمين لبرنامج البيدياتريك دنتستري بروجرام في كوريا في جامعة سول ناشونال يونيفرسيتي أو في جامعة يونسي، بسبب number of patients, it's a tertiary hospital, type of cases ما هي سهلة. فهذا حيعطيك إن شاء الله قوة لما ترجع للسعودية يكون أنت متدرب على أكثر الحالات صعوبة أو السيندرومز والميديكالي compromised patient. Dental treatment of people with special needs. There is a special hospital in the Seoul National University Hospital for special needs people. And auto transplantation of teeth. عادة auto transplantation of teeth تتميز فيها Seoul National University. هذه إحدى الكيسات ل auto transplantation of teeth for impacted canine after open the flap. We luxate the canine Then we try to make the suitable site for the canine, and the last photo for the follow-up of the case after 2 months. السكسس ريت عالي فيها فعليا صراحة. قاعدين نحاول إنه نبدأ هذا الشيء في السعودية هنا في مكة المكرمة مع الدكتورة سخاء. صراحة انترستد في هذا الموضوع وأنا كذلك، فمع التنسيق مع الديبارتمنت الثاني اللي هو الأورثودونتكس إن شاء الله حنبدأ في هذه الحالات قريبا. Completion exam. At the end of the program, as we said, the trainee should pass the completion exam. هو عبارة عن 100 question, multiple choice and short answer. List of reference for completion exam for pediatric dentistry program as shown in the photo. Pediatric dentistry department in Seoul National University Hospital. تقريبا هناك حوالي 27 عيادة أسنان في الديبارتمنت. Are 4 residents each year get acceptance and 1 foreigners. كل طبيب تقريبا أو each professor تقريبا عنده حوالي 35 إلى 40 مريض every day. عدد المرضى جدا عالي. مو كلهم يكونوا تريتمنت، ممكن يكونوا as a follow up، منهم orthodontic treatment or interceptive treatment، منهم يكونوا restorative. فالسرعة مطلوبة. في البداية كنا نشعر ان نحن ابطأ ناس بينهم، لكن هم متعودين من ايام البكالوريوس او الانترن انهم على السرعة. الاسيستنس اللي مع الدكاترة كلهم عارفين النظام مضبوط، عارفين الطبيب ايش يحتاج، حافظينه بشكل اصح بحيث انه ما يحتاج انه يطلب، هم حافظين الاستبات بشكل كامل. ففي البداية ممكن يكون أي تريني عنده صعوبة في هذا الشيء، ولكن مع الوقت إن شاء الله حيبدأ يتعود ويصير زيهم تقريبا. ال OR, there is 7 dental chair on OR. Every chair around receive 3 patients every day. Mostly the 2 comprehensive case and 1 odontome or supernumerary teeth. And this is some cases for interceptive treatment or space management and rehab cases. طبعا أنا graduated from Seoul National University as from the second batch. First batch was my friends Dr. Iman Al-Jafar. Now she is senior register head of dental department in Safwa General Hospital. أيضا خلال فترة البروجرام حيكون من الممكن أنك المشاركة في المؤتمرات العالمية. قدمنا 2 case report في Japan conference for medically compromised patient in pediatric patient. Finally, I will talk about life in Korea. in general الطقس، يعني إذا بنبغى نبدأ في الطقس في كوريا في الربيع وفي الخريف يمكن يكون أفضل أوقات الجو اعتدال في كوريا. بعدها الشتاء يكون جدا بارد في كوريا، الصيف ممطر. للعوائل اللي تحضر مع المبتعثين there is an international school British and American. أيضا المدارس السعودية تفتح في السفارات لاختبارات المرحلة المتوسطة والثانوية. رسوم المدارس مغطاة من قبل الملحقية الثقافية السعودية هناك بنسبة تقريبا 90%. التكلفة المعيشية في كوريا مرتفعة جدا، ولكن تقريبا ما يتم صرفه للمبتعث يغطي بشكل كافي جميع المصاريف هناك. التأمين الصحي في كوريا شامل من قبل الملحقية الثقافية السعودية. جميع وسائل المواصلات متوفرة في كوريا. نسبة الأمان مرتفعة صراحة هناك. طبيعي يعني انك تعيش تحس بالامان هناك والراحه. ممكن ضغط العمل فقط في كوريا هو اللي يخليك ما تستمتع مثلا في أجواء كوريا أو إنه في مناطقها بسبب ضغط العمل. حتى السبت دوام، يوم الجمعة هو عفوا يوم الأحد فقط هو العطلة الرسمية. لكن بشكل عام التجربة كانت جدا رائعة وجدا ممتازة وأنصح فيها، وأتمنى لكم التوفيق لأي شخص قبل فيها أو سيقبل إن شاء الله مستقبلا. أتمنى أني أكون وفقت في نقل جزئية بسيطة من التجربة وأجبت عن بعض التساؤلات والأشياء المتطلبة الجديدة في البرنامج الكوري. هذا إيميلي if you have any question and we can receive the question if anyone has a question about postgraduate program.
يعطيك العافية دكتور محمد. Thank you for giving us all those information. Really they are important. Welcome back للسعودية. حياك الله دكتور. في a lot of questions. I'll start with the first one. في أحد الحضوري يقول الموقع من بداية شهر نوفمبر في مشكلة وما يقدروا يعملوا تقديم. كيف يقدروا؟
صحيح، أنا تواصلت مع كيدي وأبلغوني إنه فعلا في هناك عطل في البرنامج، ولكن عطل في الويب سايت، ولكن خلال يعني الأيام القادمة إن شاء الله حيتمكنوا من إصلاح العطل. وزي ما ذكرنا إنه مدة التقديم لمدة شهرين، فهناك مدة كافية إن شاء الله للتقديم والتسجيل.
ممتاز دكتور. في محاضرتك قلت إن في شروط جديدة زي الكيس ليست. ممكن في أحد الحضور يسأل يبغى تفاصيل أكثر عن الكيس ليست؟
الكيس ليست عبارة عن 10 كيسات، هتكون scaling and root planning before and after 2 cases and root canal treatment 2 cases, single crown and posterior crown first case for each, and comprehensive case أو ما يعرف CC 2 case, photo and X-ray for all cases, medical history, dental history, and the chief complaint for each case. It's important. هم الكوريين يا دكتورة ما يحبوا يبنوا واحد من أول وجديد، يبغوا واحد عنده experience جيدة، فعشان كذا طالبين إنه يكون فعلا عشان كذا برضو طالبين إن هم يكون عنده 3 سنوات خبرة. ما يحبوا يبنوا من الصفر، أو ما يحبوا إنه يكون ويك، فيبغوا إنه واحد يكون فعلا شغال في الفيلد مظبوط، عنده كيسات، عنده good experience، السي في حقه يؤهله على إنه يدخل في مستشفيات عندها رتم عالي من العمل وعنده عدد بيشنت كبير، ما يقدر مثلا يقدر يشرح لك كل صغيرة وكبيرة، فبالتالي لازم إنه يكون well educated and has a good medical training.
ممتاز. دكتور سؤال ثاني، هل الدراسة حتكون لغة الدراسة بالكورية دكتور الدراسة بتكون بالكورية ولا عشان فقط التواصل مع المرضى الواحد يحتاج يتعلم اللغة؟
الريفرنس حيكون باللغة، الريفرنس بوكس كلها إنجليزية. المحاضرات السلايد حيكون بالإنجليزي، ولكن ليس جميع الدكاترة والبروفات يجيدوا اللغة الإنجليزية بطلاقة، ويتوقعوا منك إن خلال إنهاء هذه السنة الأولى إنك أنت تكون very excellent in Korea. فاللغة الكورية مهمة مع المرضى ومهمة مع الدراسة. صعب إنك تلاقي أكثر من بروفيسور في الديبارتمنت إنه يتكلم اللغة الإنجليزية بطلاقة وبشكل كويس. ممكن في بعض التخصصات اللي تحتوي على sedation مثل الجنرال أنستيزيا، مثل البيدياتريك دنتستري أو الماكسيلو فيشيال، يكون شوية المهمة أسهل بسبب إنه في عندك 2 أو 3 أيام في الأسبوع أندر جنرال أنستيزيا أو أندر sedation، ما حيكون في تواصل مع المريض ولا حيكون في تواصل مع أهل المريض. التريتمنت بلان حتكون جاهزة من قبل الفترة، فيعني ممكن تخصص عن تخصص يفرق، لكن in general اللغة الكورية مهمة جدا في الدراسة وفي التواصل مع المرضى.
دكتور، كونك موظف وزارة صحة، في أحد الحضور يسأل ابتعاث موظفي الصحة هل صحيح فقط 2 كل سنة؟ وكيف يقدر الشخص يزيد من فرصة قبوله؟
الابتعاث لا، ليس لكل 2 في السنة. ممكن يكون أكثر، يعني أو الدفعة الأولى كانت 14 طبيب جميعهم من وزارة الصحة ما عدا طبيب واحد من الجامعة. الدفعة الثانية اللي هي دفعتي كانت 4 أطباء جميعهم من وزارة الصحة. لا، ما هو محصور عدد معين. زيادة احتمالية القبول تتعلق في السي في، وفي غالبا في السي في، يعني انه البروفيسور زي ما قلنا انه حيقرا السي في بتمعن، حيشوف فعلا انه هل هو منخرط في التخصص، له باك جراوند جيده في التخصص، عنده ريسيرش، عنده اي اكتيفيتيز على في هذا النشاط يعني.
ممتاز. في ما شاء الله تبارك الله أسئلة مرة كثير. قلت لك موضوع مرة مهم، وعدد كبير يحاول يحصل فرص للقبول. فبس أطلب من الحضور إذا كان في أحد عنده سؤال بس يعمل ريز للهاند، وراح نعطي لهم لأكسس تو مايكروفون عشان يقدر يسأل الدكتور مباشرة. على بال ما الناس تجهز، بس دكتور دكتور ثاقب الشعلان موجود معنا اليوم ويتشكرك شخصيا، فحبيت أوصل لك الشكر.
شكرا لحضورك ويعطيك العافية دكتور.
في سؤال: do you mean the SDLE is required as a test or the mark itself will be considered؟ اللي هو الاختبار التصنيف، الاختبار اللي ينعمل.
الاختبار الآن في السنة هذه أصبح إنه requirement، لكن مو لازم إنه يكون جديد، إنه فقط إنه يكون عندك اختبار أو عندك ما يثبت إنك اجتزت امتحان الهيئة السعودية للتخصصات الصحية.
واضح. فالدرجة مو مهمة، أهم شيء الاجتياز.
إنه نعمل شيء الاجتياز، وإنه يكون مختوم ومصدق من الهيئة السعودية للتخصصات الصحية.
ممتاز. هل يجب وجود خبرة 3 سنوات ولا يمكن لحديث التخرج التقديم؟ وأين نجد أو الحالات مكتوبة؟
الجزء الثاني من السؤال ما سمعته دكتورة، معليش.
يعني السؤال الجزء الأول يقول هل إجباري 3 سنوات؟ والجزء الثاني يسأل يبغوا الحالات المطلوبة اللي هي الكيس ليست مكتوبة عشان يقدروا يعملوا لها سيف وريكوردينج.
بالنسبة للخبرة، نعم، حديثي التخرج لا يمكنهم التقديم. بعض الأحيان يعني يكون في بعض المتقدمين عندهم 2 سنتين و10 أشهر يتم استبعادهم. الكوريين دقيقين جدا في الطلبات، هي 3 سنين يعني 3 سنين. ما أنصحهم صراحة أنه يعني يقدموا، لأنه ما حيجي قبول. الحاجة الثانية بالنسبة لل10 كيسز، هي موجودة داخل النيو ريكوايرمنت، موجودة داخل الويب سايت، لكن بسبب أنه ممكن يكون الويب سايت ما قاعد يفتح، هم ما قاعد يشوفوها، ولكن هي موجودة من ضمن أول ما يفتحوا الويب سايت حيلاقوها. وأيضا بإذن الله إذا أحد يحب أنه يأخذها عن طريق الإيميل، أنا حرسل له هي عن طريق الإيميل.
ممتاز. دكتور، في محاضرتك ذكرت list of universities والجامعات والكليات الموجودة في كوريا. هل جميعها معتمدة من قبل الهيئة السعودية للتخصصات الصحية وزارة التعليم العالي أو الطالب يبحث المتقدم؟
لا، ال4 هذه جميعها ما فيها أي مشكلة وما عليها أي خلاف، وجميعها معترف فيها. أول برنامج أصلا معترف فيه من الهيئة السعودية للتخصصات، بغض النظر عن الجامعة اللي أنت جاي منها. هو المهم عند هيئة التخصصات أنه إكمال المرحلة التدريبية، اجتياز الامتحان، التقدم على الاختبار في الهيئة السعودية للتخصصات الصحية عند العودة بعد ما تخلص الداتا فلو أيضا. بعدها في حال أنك اجتزت الامتحان حتتصنف سينيور ريجستر بكل سهولة. يعني أنا ما أخذ معي الموضوع يمكن 15 يوم.
ما شاء الله تبارك الله، بالتوفيق. في أحد لو عنده سؤال يعمل ريز للهاند؟ ما شاء الله الشات شكر وأسئلة. يعطيك العافية دكتور.
الله يسعدك يا رب.
أتوقع كذا ما صار في أحد عمل هاند ريزنج. في دكتور محسن، لو تقدر تفتح الميكروفون وتسأل سؤالك.
السلام عليكم، تسمعوني؟
السلام
وعليكم
عليكم.
السلام.
بس سؤالي للدكتور، يعني هو بيقول انه اجتاز اخر اختبار للكوريان لانجويج، دي الدرجه هي صعبه، ومعلش التست لو هو فيكست، هل معناه انه انا حتى لو خلصت 13 شهر لازم انتظر، ولا الملحقيه وقتها حتطالبني بالرجوع؟
الامتحان ما هو سهل صراحة. أنا ما اجتزت إلا في آخر فرصة، وهي قبل بداية البرنامج في 15 يوم برضو أو شهر تقريبا. الاختبار نعم صعب، ما هو سهل. جميع المبتعثين ممكن يفيدوك في هذا الكلام. الامتحان ما هو سهل. الحاجة الثانية، في حال أنه بدأت السنة الأكاديمية اللي هي في مارش وما حصل المتقدم او الطبيب على التوبيك 3 اكزام، توبيك 3 في اللغه الكوريه، ما حيدخل الامتحان. ومن بين المتقدمين للاسف واحد منهم رجع للسعوديه بسبب عدم اجتياز الامتحان. من ال 47 اللي جو على كوريا، واحد منهم فقط رجع للسعوديه بسبب عدم اجتياز الامتحان. حتى موظفين ارامكو كانوا من قبل يرسلوا على كوريا. يعني في احدى اللقاءات تقريبا 99% منهم يجتاز، ولكن يعني في نسبة بسيطة جدا إذا ما اجتازت ما حيدخل على الجامعة، لأنه هذا شرط في الجامعات الكورية وليس من الملحقية السعودية أو من وزارة التعليم.
يعطيك العافية دكتور. آخر سؤال عشان نلحق الوقت. دكتور منتهى، إذا تفتح الميكروفون بليز.
السلام عليكم.
السلام.
كيف حالك دكتور؟ دكتور محمد، كنت أبغى أسألك لو في شخص مجتاز اختبار البورد السعودي في تخصص أسنان الأطفال، بس يعني ما حصل على شهادة البورد، هل هذا يساعده هناك إنه هو ياخذ مثلا يدخل على الاختبار على طول زي البورد الأردني أو كذا، ولا الموضوع هذا ما هو؟
في كوريا لا، الموضوع هذا ما هو وارد. ما يعني حتى في بعض المتقدمين كانوا حاصلين على الماستر وتقدموا على البرنامج الكوري، ممكن يعطيكي أولوية في القبول من أول وجديد في البرنامج الكوري، ولكن ما حيكون يعني ما عندهم زي هذه الأشياء في كوريا، أنه ممكن مثلا تدخلي أنت من الأخير على الامتحان. ممكن في البورد الأردني ممكن يقبل هذا الشيء، خاصة إذا كان في عندك ماستر. البورد الأردني يقبل أنك أنت تاخذي الاختبار. البورد الأردني في حال أنه عندك ماستر وعندك شهادة إنهاء تدريب من الهيئة السعودية للتخصصات الصحية.
يعطيك العافية دكتور. would like to welcome again Dr. Justin. شكرا دكتور محمد for your presentation. On behalf of the Saudi Society of Pediatric Dentistry, I would like to thank you all for your time, for your effort, for your presentation. Really, it's a great scientific day for today. Personally, I learned a lot. يعطيكم العافية. Thank you, Dr. Justin. I would like to present a certificate from the Saudi Society of Pediatric Dentistry to both of you, Dr. Justin Lee and Dr. Mohammad. And if we can just, with the organizer, if you can present the picture or the certificate for Dr. Justin first, please. And the second certificate will go for Dr. Mohammad. And at the end, I would like to thank the audience, the presenter, and the organizer for giving those efforts and for everything to make this night a great night. Thank you everyone. فمان الله، مع السلامة، ونشوفكم على خير في the coming webinar بإذن الله. مع السلامة. فمان الله. Dr. Justin, yes, please, if you can share the references you mentioned to us, please. Some of the presenter, the audience want to have a copy of the references.
Okay, yeah, I will show my presentation. Okay. Oops, sorry. This book can be bought in orthotropics.com, and the other books you can buy on Amazon or other bookshops. It's very easy and easy reading books, except the causes and cure of malocclusion. But if you read this, you can get some more information and about the concept, the right growth, direction, and patterns. Yeah, it's my great honor and pleasure to meet you all in Saudi Society of the Pediatric Dentist. Yeah, it's a good opportunity to meet you all. If you have any questions, please send me your email. My email address is childdentist.com. Yeah, always welcome. So nice to meet you.
Thank you, Doctor. I know it's already 3 or 4 a.m. on your time, and we are really appreciating your time. Sorry. Good night, and we are really sorry.
Yeah. Okay.
Bye-bye.
Thank you for the invitation again. Okay, bye.
Bye. Goodbye.